into two main sections, and so I'll start with providing a general overview about LGBT veterans and some of the spiritual issues that come up, and then Chaplain Ballard will talk about kind of the role of chaplains in navigating kind of spiritual healing. So my name is Dr. Lang Altman. I am the PTSD substance use psychologist at the Hampton VA, and the other hat that I wear proudly is I am the LGBT veteran care coordinator. So what that means is I'm a point of contact, a veteran advocate, a source of information about policies, directives, and I just work to kind of increase awareness about LGBT veterans. Okay, so let me figure out how to work this. All right, good. So some of the things that I hope you all take away from this is just becoming a little bit more familiar with the terminology relevant to the LGBT community, get a greater awareness of the unique care concerns for this population of veterans, reflect upon our own personal views and ways that we can then improve our interactions with LGBT veterans, and then learning about some of the common spiritual issues and cultural considerations that can come up with working with LGBT veterans. So here's an overview of the presentation, the portion that I'll be covering so that you have a general idea as we kind of move along in case you have any questions that may come up. So we'll start with just a general overview of terminology and definitions just to kind of lay the groundwork. So if we see here, the term lesbian is a woman who is primarily attracted to other women. Gay is an individual who is primarily attracted to members of the same sex. Oftentimes we use this to refer to males, but not always. There's a number of female veterans that I work with who prefer the term gay over lesbian. This comes up a lot with the community. The point being is that the individual gets to choose the term that is most reflective and fitting for them. So even if you see a definition during this presentation, it's ultimately up to how the veteran self-identifies. Bisexual is an individual who is attracted to both people of their own gender as well as the opposite gender. This is not always equally split, not always just depending on who's available at that time. It's a whole kind of continuum of attraction and understanding. And then transgender, this is a pretty big umbrella term that just kind of covers a whole range of identities for people who don't necessarily fit into those check boxes that we have in society of male and female. It's a whole big umbrella. And so one of the things, the fancy word that you all will learn today is heteronormativity. What that term means is that oftentimes we have assumptions when we first meet people. And so for the LGBT community, a lot of times that we have the assumption that people are straight until proven otherwise. It's just kind of how we try to simplify the world. And so just knowing that sometimes we carry that in when we interact with other people, especially in our word choices. So if we ask about marital status over relationship status. So just knowing that that plays a factor. So as you can see, these are color coordinated. So lesbian, gay, and bisexual groups are related by sexual orientation, and you see how that's green, where transgender groups are related by gender identity, and those are purple. So when we look at this, this is a continuum of experiences. As I kind of already mentioned, we tend to think about things in checkboxes, this or that, gay or straight, male or female. But really what we know in terms of kind of research, both psychological and medically based, is that we are much more complicated than just checkboxes. There's a whole range of identities out there. The first one, sexual orientation, who we love, our emotional, romantic attraction to other people. On one end, we can be attracted primarily to females. On the other end, we can be attracted primarily to males, or we can be anywhere along that continuum. Sometimes that changes over the lifetime, sometimes not. And there's a whole number of terminology that fits in this continuum as well. Bisexual, we already talked about, asexual, and pansexual. You may notice as I go through this presentation that there's quite a bit of terms for this population. So one of the handouts that you all have, the accompanying resources, is actually a list of LGBT terms and definitions. So hopefully that helps out. The next continuum of identity, this is completely different than sexual orientation. This is biological sex, or the bits and pieces that we're born with. So our anatomy, our chromosomes, our hormones. On one end, we can be biologically primarily male. On the other end, we can be biologically primarily female, or we can be anywhere on that continuum. We can be a combination. We can have, anatomy that doesn't necessarily line up with chromosomes or line up with hormones, and we can be a combination of male and female biology. The medical term for that is intersex. Some of you all may be familiar with a term that was used a little bit more in the 80s, hermaphrodite. That's considered to be an unfriendly and medically not relevant term now. So the term that we use is intersex. And then the last continuum of identity that we'll cover for this presentation is gender identity. This is our psychological sense of self. This is what our brain tells us in terms of our understanding of gender. We can be primarily man in our understanding of our gender, or primarily woman in our understanding of our gender. And similar to the other continuums, we can be anywhere along that continuum. So that's where you start to see the terms transgender, two-spirit, pangender. Now, you may be looking at this and notice, for biological sex, a lot of times that lines up for people in terms of their gender identity, meaning biologically, kind of what I see on the outside matches what's in my brain, right? So me, for instance, biologically, as far as I know, I am primarily female, and my brain aligns with that. My brain my sense of self is woman. The term for that is cisgender, meaning it matches up, it lines up, and you can see how it lines up on the continuums as well. But for some people, that doesn't line up. So if biologically I'm primarily female, but my brain is telling me that I understand myself as male, you see how those don't line up on those two continuums? That's transgender. That's gender dysphoria. And so when that happens, that's a pretty uncomfortable feeling for people. I mean, can you imagine what it would be like if my brain is telling me one thing and it doesn't necessarily match with kind of my body? And so that involves a number of kind of unique care considerations. Another way to kind of look at this is the genderbread person. So you can see how all of these continuums kind of go in together for one individual. So you see at the top where gender identity is, that's our psychological sense of self. You can see where romantic attraction has to do in the heart, so sexual orientation. And then there's biological sex. And you see, all of us have these continuums of identity. They just might not be as relevant for us unless it doesn't match into what society says is the norm, right? And so with all of these things, while we're focusing on, specific continuums of identity, you can see here that there are just certain aspects of what makes up a total person. So just because we know someone's biological sex doesn't mean we know anything about their religion or their spirituality, right? We can't tell that just by looking at somebody. Same thing as if we know that someone, how they identified sexual orientation-wise, like if they identify as gay. That doesn't mean we know anything about how old they are, their veteran status, their race, ethnicity. So just like you would with any other veteran, a part of this is just taking into consideration the totality of the person. So some points to remember. Terminology is important. The veteran gets to choose how they self-identify. Knowing the difference between sexual orientation and gender identity. If there's anything that I hope you take away from this presentation is that knowing that those are two different parts of who a person is. A lot of times when I hear frustrations from the veterans, it's because those things get kind of confused. So if you walk in just knowing that sexual orientation, who I love, is different than gender identity, who I am, you're already ahead of the curve. And then knowing that they occur on a continuum. It's not necessarily either or. We all know this. We all know that we're much more complicated than a checkbox, and yet, remember that fancy word, heteronormativity? We try to simplify our world, and we do that with people too. And then the LGBT community is extremely diverse, right? Just because you've met one individual who identifies as lesbian doesn't mean that you know anything about someone else who identifies as lesbian. Each person is their own unique person. So in going into healthcare disparities, this may be a phrase that some of you all have heard before, and this is absolutely relevant to the LGBT community. A lot of times they're considered the invisible minority. Reason being is we oftentimes don't see someone's LGBT status by just looking at them, right? And in addition, LGBT individuals also struggle with accepting their own internal identity, because a lot of times they hear those messages from society that there's something wrong with me, right? That's in conflict as well. And that amount of stress over time can actually make differences in someone's health care. And so healthcare disparities is what happens when there's a minority group or a minority population that has a different access to kind of healthcare or different unique kind of care concerns that may be coming up. So the reason why healthcare disparities
Dr. Langotman, I need to stop you for a second. I'm not sure what happened, but the screen has either been taken over by someone else or it was shifted. Because we're not seeing your presentation.
Let's see how to fix that.
I apologize.
That's okay. No, let me know if it all of a sudden pops away.
Okay, you're back.
Oh, I don't know what happened then. Okay, perfect. So the healthcare disparities that happen for LGBT individuals, some of the reasons why this occurs are those stressors from society. It's a number of things that we've all heard. We've heard those negative messages against LGBT individuals. We've heard some of those oftentimes hateful comments that can get made. LGBT individuals hear that too, and that's going to have a negative impact. I mean, imagine hearing some negative message over and over and over again about who I am. Eventually we tend to take that stuff on, right? Then in addition, there tends to be a lack of awareness about care concerns for LGBT individuals, right? So if I identify as gay and I go to my primary care doctor and they're talking to me about what I'm doing for birth control, right? Like that might not be relevant for me, but they might not be asking what I'm doing to maybe prevent HIV. The dialogue kind of changes. There can be a concern of a rejection from providers, which absolutely does happen, a refusal of care, a delay in access to care, so not placing those consults to get connected to other services. There's absolutely mistreatment that can happen in healthcare appointments. And then there's little or no inclusion in outreach efforts. The VA does a wonderful job reaching out for suicide prevention, trying to get out in the community. And oftentimes we don't do the same kind of efforts for LGBT veterans. So some of the healthcare disparities that come up, as you can see, there's an increased risk for suicidal ideation and attempts, just like our larger veteran population, increased risk of discrimination. Our LGBT veterans actually have an increased risk of exposure to combat and sexual trauma. We'll talk a little bit more about that in a few minutes. Increased risk of intimate partner violence or domestic violence. Increased risk of mental health illnesses, substance use, which makes sense, those negative messages from society has an impact on someone, and an increased risk of HIV exposure. That leads to a lower overall health status, pretty much across the board, lower overall health status. Less likely to go to routine and preventative care appointments. If I feel like my doctor is going to reject me, I'm just not going to go, right? Which then can lead to actually increased risk for certain types of cancer. If I'm not going to my preventative care appointments and getting those early on screenings and taking care of myself, things tend to progress negatively. And as we've talked about, a lack of inclusion and outreach efforts and less likely to have access to care. So at the VA, one of the things that we commonly talk about is the suicide risk of our veterans. We know, working at the VA, that our veterans are more at risk for suicide than the general civilian population. We oftentimes hear the scary statistic of 22 veterans a day. But if we look at kind of the breakdown of that and what type of veterans, are more at risk, what we see is that 22% of our heterosexual, so our general veteran population, has experienced suicidal ideation in a lifetime. A number of us could probably look at our caseload and say, yeah, that sounds about right. between 1 in 4, 1 in 5 suicidal ideation as a factor. And then we look at kind of our lesbian, gay, and bisexual veterans, so sexual orientation. That jumps up to 47%. So already we see how that stress is kind of increasing that risk. And then we look at our transgender veterans, gender identity. That jumps up to 66% experience suicidal ideation in a lifetime. So you see how that just continues to kind of keep in mind. The scary statistic is that the risk of suicidal behavior is 20 times higher for our transgender veterans than our general veteran population. So that's just not having the thought, that's actually acting upon it. So I'm going to read a comment that just came up. So please keep in mind the cultural attitudes towards someone being gay. For example, a black gay soldier receiving treatment in a VA clinic with a black female employee who has negative feelings towards being black and being gay. This tends to keep black gay soldiers in the shadows about their sexuality. Excellent point. I was actually just with our infectious disease coordinator. She comes to the LGBT group that I lead, and we were talking about the additive effect of healthcare disparities for minority populations. So what that means is that someone who identifies as LGBT means that they're more at risk for certain healthcare disparities. And then we know that individuals who are black are also at risk for certain healthcare disparities. So if you're an individual who is LGBT and black, you get double the stressors, which makes it that much more likely that you're going to get healthcare disparities. So you're absolutely right. It has an additive effect. So the more minority populations that I identify with, the more at risk I am for certain healthcare disparities that come up. So excellent point. I'm glad you brought that up. And so it's difficult to talk about kind of healthcare disparities without kind of looking at, some of the things that may have added to the stressors before we even see them. So we'll start off with military culture. When we think about the military, we don't necessarily think about rainbows everywhere, right? We think about the military having a certain environment, a certain culture, and absolutely, there is a history of stigma in military policies against sexual and gender minorities. While there's been some progress, there's also been some slip back. In 2010 was the repeal of Don't Ask, Don't Tell. This ended the ban of lesbian, gay, and bisexual, so sexual orientation individuals. Now they can serve openly. In 2016, the ban was lifted on transgender service. So that allowed for transgender people to serve openly in the military. And as some of you all may know, is that a lot of this has been called into question. And while they're not calling it a ban, there are restrictions that have been put in place within the past month about transgender service and being able to serve openly and the diagnosis of gender dysphoria. And so that's something on the active duty side that a lot of my counterparts, because here in Hampton Roads, we have every military branch represented within like an hour radius. And so I know they're actively trying to navigate what does that mean for our active duty service members. What that means for the VA is that we will have to be prepared for a number of individuals who have come forward, and openly served and then had to go back into the closet. Because there's absolutely stress that comes with concealing one's identity. So if there's a part of me that I find to be really important and I can't talk about it for fear of punishment, fear of getting kicked out of the military, fear of, physically being attacked, that's going to add stress to an individual in addition to the stressors that we know all of our veterans experience, right, in military service. So our LGBT kind of service members have high rates of combat exposure, which makes sense, right? If I'm hiding this part of who I am, a lot will cope with that through signing up for riskier missions, repeat tour of duties, because I am going to be the best service member possible, so that it's something that nobody will look at, right? So if I got you looking over here at all these like wonderful achievements that I'm doing, means you might not be questioning if I'm LGBT or not. So what we also know is that people who have high rates of combat exposure are also more likely to experience military sexual trauma. So again, you see how these things can kind of add upon.
Combat exposure.
Combat exposure. Yep. So I don't know whose phone wasn't muted, but it sounds like that was a pretty shocking kind of something to consider.
Very shocking.
You weren't.
Pretty shocking. And where did you get that from?
So is this something that's calling? So is it possible, because there's a little bit of static on the phone, it sounds like when you unmuted, is it possible for you to write your comment in the chat box? That way I can make sure to respond to it.
Sure.
Yeah, because it's interesting. So as I mentioned at the beginning of the presentation, one of my duties here is I'm the PTSD substance use psychologist. So I work primarily with veterans who have military-related, combat-related traumatic experiences and therefore PTSD, and you'd be surprised at how often those hats kind of come together and overlap. So absolutely, a number of our LGBT kind of service members do serve and, are in kind of positions in which they are exposed to combat. I think at the bottom of the slide, I cannot find documentation. Oh, where does the statistic come from? Yes, absolutely. So the veteran population, it is estimated that there are 1 million LGBT veterans in the country. That estimate is based upon multiple factors from the National LGBT Program in terms of the statistics of the civilian population, kind of what we know. But at the same time, the VA does not systemically track sexual orientation and gender identity. That will be a part of our new electronic medical record. And the statistic is from 2016 when it looked at how many veterans total are in the United States. In 2016, there were 20 million veterans total in our United States, those who identified. I'm sure some didn't claim veteran status. So what that breaks down to is, based on the estimates, is that there's about 1 in 20 veterans who identify as lesbian, gay, bisexual, and transgender. As a military chaplain, maybe I read the quote wrong, that those who have been in military combat experience sexual trauma. Yeah, no, those were not equated. That was a comma in between those. Yeah, that wasn't. So are these just guesses at this point? These are educated estimates based upon, the proportion of people who are out there. Okay. So at the VA, since, we are knowing and recognizing that we do have a high proportion of LGBT individuals that we provide care to, in 2012, they created the National Office for Patient Care Services in the LGBT program. That national program is tasked with doing a lot of the policy recommendations, doing education programs, and kind of focusing on how do we have clinical services geared towards our LGBT population. And what we know working at the VA is we have a lot of policies and a lot of directives out there, and so it can be difficult to actually implement those at each facility. So in 2016, the national program created the LGBT coordinator position, meaning that there is a point of contact for LGBT veterans at every facility across the country. So there is one of me everywhere. So I'm just kind of curious, since we do have this beautiful little chat box, is how many people know who your LGBT coordinator is at your facility? Excellent. Orlando, I know yours. She's great. Wonderful. That's amazing. That's great. Yes, know this person. Put them to work. If you have questions about policies, directives, I know Johnson City too. So if you all put these people to work. If you have questions about care concerns, policies, directives, this is the person who is tasked to do that. And if you need help locating that person, maybe they may be new to the role, or you just haven't kind of considered this as much, or even knew that this position was out there, this link will get you to our VA National SharePoint site that will help you find out who that person is, or feel free to email me. I am the only Tiffany Lang Altman in the email system, if you can believe that. And I will be more than happy to help you get connected with that person. They're a great resource. So in regards to the VA and kind of some of the things that we're doing to be kind of proactive with care and taking care of our LGBT veterans, and I summarized them for you all. I also gave you all kind of the links for the more in-depth one, but I just wanted to summarize some of the main points, is knowing that we will provide respectful quality care to veterans and anyone they identify as family. They do not have to be blood related, legally married. Anyone they identify as family counts as family at the VA. Knowing that LGBT status is confidential patient information. It's considered a part of someone's health status. And so, you know, if you were to disclose that someone identifies as transgender and it's not related to their health care, like if you're just kind of talking in the hallway, that's actually a HIPAA violation. So LGBT status is confidential patient information. In regards to medical decision making at the VA, our veterans can designate anyone of their choice, including a same-sex partner, to assist them for medical decisions. All of our non-discrimination policies, all of them, are LGBT inclusive for patients and employees. So I know a lot of what we're focused on is veterans, then at the same time we have quite a few LGBT employees too. We do have equal visitation policies for things like CLC, you know, the med unit, so on and so forth, for all of our patients and our visitors. And then also knowing that any attempts, formal or informal, by any VA staff member to either convert or change a veteran's sexual orientation will be addressed by corrective actions and training. So we don't engage in any of that kind of at the VA, and we'll talk more about that. Regarding the last point on this slide, please clarify what Directive 1340 means by formal versus informal. Kindly give some examples to clarify because I couldn't find anything to describe this in 1340. Correct. A lot of the directives will state something, but then it's ultimately up to kind of facility procedures for this. So what you are talking about, any attempts, formal or informal. So things like actively engaging in conversion therapy and having that dialogue with a veteran, and even if you two mutually agree to it, so that would be a formal attempt to try to change someone's sexual orientation. That is not allowed. Informal would be, let's say I'm having a care appointment with someone, let's say they're coming to me.
This is Kristen. We're waiting. Yes, Dr. Lang-Altman, we see that you've been kicked off, so we'll just wait a minute till you get dialed back in. Is everyone else still on?
Yes.
I'm here.
Okay, good. I was just checking in.
Still here.
Thank you guys for hanging in there. And you've had some great questions and feedback. Dr. Lang-Altman, are you back with us?
Have I been able to join back?
Yes, you're here.
Wow, all of a sudden, it just like everything went quiet. And you all are able to still see my presentation?
Yes, we can see it.
Yes, we can see it.
Thank you. Sorry, technology woes. I'm not sure what's happening. Okay. So this gets much more in depth to tie into the question that was just asked. This gets much more in depth about like our specific policies and procedures. And so you all will have a copy of this, and then I also created a handout that summarizes a lot of these. Like I said, your LGBT veteran care coordinator is ultimately responsible for knowing the ins and outs about this. But I just wanted to make sure that you all knew that these are available. So, you know, as you're coming and working with veterans, you at least know what these references are. This is the Directive 1340 that I was referencing on the last slide. It's about providing health care for transgender and intersex veterans. And so the formal or informal that has to do, I think more with like interpretation and dialoguing about that. If there's any specific questions, really your facility LGBT coordinator is the best point of reference. At the VA, we provide affirmative care. We'll talk a little bit more about what that means and how that might differ from other approaches to care. And so you can see even there's like policies about women's health clinics having an inclusive definition and how to do identity changes in the health record. This is just in there for your own kind of frame of reference, knowing that these are out there. But if there's any specifics about getting into the kind of the weeds of these things, just ask your LGBT coordinator. Okay, so moving forward, knowing that, part of this presentation is just to start the dialogue and increase awareness about LGBT veterans. It's not meant to be an end-all, be-all. So knowing to start off with some helpful interactions with the basics is just knowing the difference between gender identity and sexual orientation. So who I am is different than who I love. Asking about correct terminology for identification and not assuming. A lot of times when we assume, that leads to us putting our foot in our mouth, and that's always a little salty and it's uncomfortable. So, but it happens. I work with the LGBT population a lot, and pronouns are hard. They know pronouns are difficult, and so even, when I make a mistake, I acknowledge it. I'm like, I'm sorry, how can I do better next time? And then you actually have to try to do better kind of next time. Yes, I hear about that one a lot. So the National Geographic had an excellent presentation on this subject entitled Gender Revolution in January 2017. It is an extremely helpful resource, knowing they focused a lot more on gender identity and not necessarily sexual orientation. So as long as you kind of going back to knowing that those two continuums of identity are different, but absolutely, it's very interesting. One of the things that you can do to have a helpful interaction is to call veterans from the waiting room by last name only. This is actually encouraged in some of the national policies and directives. I do this a lot in my clinical role as well as a psychologist. So the first time that I'm meeting a veteran, I'll go to the waiting room and I say, Veteran Smith. And then I introduce myself. I'm like, hi, I'm Dr. Lang Altman. You can call me Dr. Lang. What would you like to be called? And so it's woven into how I build rapport now rather than doing small talk about the weather. And so and you'd be surprised how often this seems to make a difference for veterans, even the ones who don't identify as LGBT. Like I have a lot of veterans that will tell me, oh, please call me Tim, don't call me Timothy. That's what my mother used to call me. I'm like, okay. And then we have some veterans that are like, call me Captain Smith. And you're like, okay. So just knowing it just gives them an opportunity to be able to have that dialogue for their preference before care even happens. And then knowing that it's VA policy that patients will be addressed and referred to based upon their self-identified gender. So if you look in the chart and it says, Joe Smith, biological sex male, and you go to the waiting room and you say Veteran Smith and you meet someone and she says, hi, my name is Jill. Regardless of what's in the chart, that veteran is Jill with feminine pronouns, she and her. So that can be helpful. So providing affirmative care. So this is kind of the stance of the VA. And affirmative care means embracing kind of the natural diversity of the human experience in regards to gender and sexual orientation. So one of the things that you can do to kind of embody that is to make your area a safe zone. So at the Hampton VA, this is the image that we use throughout the entire facility. All the providers who complete affirmative care training with me earn these magnets. And actually, I travel to other VAs and do these trainings as well. So this image very well might be in your facility too. And when I used to do these trainings in person, the chaplains would earn this magnet as well. So if you want one, send me an email. I will mail you one. Yes. Where are you? And which VA are you at? So someone has seen it. Yeah. Yep. Try our best to like kind of just spread the information out there, because it's a visible symbol. So veterans, when they see it, they know that they can have a dialogue about it. I've had this image in my office for about 4 or 5 years. I have never had anyone comment on it where it wasn't personally relevant. So what that means is, like I said, the majority of clinical work that I do is with veterans who have combat-related PTSD. I've never had anyone comment on it unless they did identify as LGBT. So it just, it sends a message to who you want it to send a message to. Yes, great, absolutely. All of those things matter. So keep doing that. Keep creating your own safe zones. It really does make a difference. At the VA, we're kind of limited on what we can do kind of paperwork and electronic record-wise. But in the places where we can and we do have control over there, it can be really helpful just to, provide a blank space for someone to put in their desired names and their pronouns. And then we make an effort to kind of use them. So one of the things that I do when I work with LGBT veterans, knowing that we are restricted to CPRS right now, is when the name is different than what might be in the chart, I'm like, is it okay if I just make a note at the top for myself, and then that way I know every appointment I have afterwards, I know preferred name, and then I use that. Another way to provide affirmative care is to challenge the binary, the either or that, the male or female, the gay or straight, because we are way more complicated than that. And so if it's something that I don't necessarily understand, that's okay, right? It's just something that I don't understand. It doesn't mean that I have to label it as kind of bad or wrong or shy away from it. It just might not be my experience, right? Pursue additional training and consultation. So like I said, this is not meant to be an end-all, be-all. It's supposed to, start the dialogue, have the conversation, get you starting to think. And then knowing that conversion therapy, so sexual orientation change efforts, reparative therapy, whatever you want to kind of call it, has been deemed unethical, harmful, and not effective by pretty much every national organization and research. Just across the board, it increases risk for suicidal ideation, and it just doesn't work. And as I said, it's against VA policy. So beyond the job, because we know we take our stuff home with us even when we try not to. So engaging in self-reflection, a skill that a number of us already do, being in the helping field. Being aware of our own assumptions and kind of personal privilege that comes into the room even if we don't realize it. So if at any point in this presentation you had a moment where you were like, what? I don't know about that. That makes me uncomfortable. That's okay. Have that now and sit with that and ask yourself, like, where is that coming from? Is it coming from messages I had when I was younger? Is it coming from, I'm just not as familiar with these things? And then figure out how you're going to navigate that, because those reactions that come up, they come up in the room with veterans. And they watch us a lot more than we're watching them. And so figure out, like, how do I navigate that? How do I hold to that so I can still provide care to the veteran who's sitting across from me? Because we provide care to veterans first, right? And then just knowing that, for some individuals, the tensions between kind of religion, spirituality, and kind of LGBT identity might be challenging for some people to kind of reconcile. And so I always liked this quote, is that cultural competence begins with cultural humility, meaning I got to find comfort in what I don't know first before I can try to understand someone who might be different from me. So additional training and resources, in case this is something that you kind of want to go a little bit more in depth about. So the Human Rights Campaign does offer free continuing education training. I can speak from experience and a number of staff members who have taken these trainings that they're extremely interesting and interactive for being a web-based. They are not like TMS. You're not just going to want to like click through them. And so the ones that I get the most positive feedback on are an introduction to your LGBTQ patients and transgender health. Those ones tend to kind of have the most information that people find to be immediately relevant. In addition, here's a number of kind of links if you're wanting specific LGBT veteran trainings by the national program. Information about policies and resources for veterans and employees. You can see we have a national diversity page. We do have internal SharePoint sites that are great for being able to kind of locate VA-specific resources, posters, anything like that. Colleague just asked, what is a good peer-reviewed article to read on the brain affecting gender? Biology says that you are one gender when your brain is telling you something else. It's interesting. So the endocrinologist that I work with, much more in depth about this because he's an MD, so his brain just works that way. There's actually a structure in the brain that houses gender. So if you shoot me an email, I will follow up with him and try to get an article because he comes to our LGBT group and he does a whole entire presentation on this. So I would much rather give you the source from somebody who can kind of speak in depth than try to kind of summarize something that's just a little bit beyond the scope of this presentation. Absolutely. And then lastly, I wanted to make sure that everyone had the email address for the LGBT program. So if you ever have any questions or like, let's say you're having a hard time figuring out who your LGBT coordinator is or any of this stuff, you can just email the national program and they'll help you navigate anything that might be coming up for you. And then a link to all of our kind of directives and memorandums so that you have access to those. But like I said, your LGBT coordinator is responsible for these. So wanting to kind of see if there's any questions or comments for me before we hand it over to Chaplain Ballard, who is very well versed in taking care of the spiritual concerns for our LGBT veterans and leads our LGBT spirituality group here. But any specific questions for me before I hand it over? Okay, awesome. Well, like I said, if there are anything or something comes up later, feel free to email me and just let me know. Otherwise, I will give it over to Chaplain Ballard. Thank you.
Well, good morning. Good morning. My name is Chaplain Ballard. I'm one of the staff chaplains here at the Hampton VA Medical Center. I work in the Family Support program out at the Chesapeake CBOT. Good morning. Hi, Dallas. I do the individual, marriage, and family counseling. I'm also an ACPE certified educator candidate, and I'm one of the educators here that do the extended units. So one of the things I want to talk to you about today is one of the many outpatient spirituality groups that I do is the LGBTQIA plus spirituality group. And I do add the additional letters to try to be as inclusive as possible with the name. I partnered with Dr. Lang Altman this morning to kind of give you an example of how to utilize the wealth of information in which she provided. And I believe that there's only one or two spirituality groups of this sort throughout the VA. So to give you a little backstory, I only got a couple of minutes here, so I'll make it quick. About 2 years ago, I was voluntold, and I did use that word correctly, voluntold by my chief, to develop a spirituality group for the LGBT population. And so although I had been an advocate for many years with inclusion and diversity, I honestly never really considered what it meant to provide spirituality to this group. So I began to do some research on best practices, and I found some interesting books and articles, but I did not really find a lot, so I had to begin to develop my own. And so one of the things in which I found is that their spirituality needs were no different from anybody else's. Connection to what is sacred and what is divine, acceptance, significance, purpose, belonging, meaning, and love. These are things that all of humanity shares. One of the things that I did find interesting was this struggle between self-acceptance and religion rejection, or religion acceptance and self-rejection. And it baffled me, and it really hit hard, and it really pulled me in and motivated me to want to learn more and to be a part of this journey. So the next slide, please. The next one. I think these are still some of yours here. The next one. Keep going. And one more, let's see. Dr. Lane, these were still some of yours here. Okay, here we go. There we go. So I talked about wanting to know more about caring for the needs of these individuals and doing some of the research. So willingness to know, grow, and show. The lack of knowledge, awareness, prejudice, and some religious politics have put a wedge between this community and many of the faith communities, and that's something that we are already fully aware of. But I saw here in doing the research that many of these individuals that are veterans were experiencing spiritual distress, moral injury, and religious trauma. Spiritual distress being a disturbance of a person's belief system or life principles that pervade their personal being. Moral injury, an injury to an individual's moral consciousness resulting from an act of perceived moral transgression. And religious trauma syndrome, which is a condition experienced by people who are struggling with leaving an authoritarian, dogmatic religion and coping with the damage of this indoctrination. So I was looking at how these individuals who I was about to serve is what impact could I provide in understanding what they were going through. And some of the things in which I found that they were dealing with was rejection, depression, anxiety, abandonment, anger, loneliness, loss of meaning and purpose, breaks in relationship, isolation, sense of damnation, and loss of community. So I was looking to develop a group that was going to create a welcome space, safety. Need to hear more about religious rejection. Okay. Creating a welcome, safe, and connection with group and beyond. So the religious rejection, many people, as the group got started, so I'm getting a little bit ahead of myself to talk about the religious rejection. In the group setting, many people were talking about as they came out and as they struggled with their own identity, that the pastors and the religious leaders were speaking against homosexuality and that being eternal damnation. So they were dealing with, do I be who I am and come out, or do I make a choice of being a part of this religious community and keeping it quiet? So there was the internal struggle with that. So one of the ways in which I gave voice to that and allowed them to talk about those experiences is to create this welcome, safe, and connected environment. So I designed a 10-week group module that dealt with some thematic issues surrounding some of those things. So I try to create a safe place, and I use Yalom, group dynamics, and you can find his book and different informations about how to go about utilizing that. And Yalom talked about considering the life cycle of the group, the formation, the process, and the dissolution. I used narrative therapy model with Michael White, and he talked about helping individuals identify their values and attaching meaning to their life experiences and spiritual journeys. And I also used some internal family system with Richard Schwartz to bring about an understanding of their parts and what it means to be a whole person and to go along this journey. Let me see what this is saying here. Can you share if race was a factor in this understanding of self? Did Black gays feel the same as white gays? Did Black gays feel an additional issue with other Blacks, meaning straight Black folks? Okay. We considered a lot of different things. The primary concern was the identification and orientation that the individuals presented with. And race was a part of it, family of origin, different forms of mental illness, where they grew up with, their different faith practices. So all of those things were considered, and we can talk about that more offline and how that impacted the group. So these are some of the models in which I use. The next slide, I talked about how to prepare for the journey. So if you're interested in, possibly establishing a group like this in your VA, some of the things that you may want to consider is number one, doing a personal inventory of your own thoughts, beliefs, and limitations. I had to wrestle with mine. What did it mean to do this? What were some of the religious and political things that, I would have to consider? And also my own ignorance. I did not know a lot. And so one of the things in which I did was to partner with Dr. Lang Altman, who is our LGBT coordinator. And she took me through the slides, and we sat for several weeks to talk about, how to use proper pronouns, what different terminologies meant, how to understand a continuum and some of the different struggles in which they face. So I sat with Dr. Lang Altman to get my own education so that I would know how to approach this appropriately and to try not to offend. But just like she said in her own presentation, there were many times that I just had to apologize and admit to my own ignorance and just keep it moving. And because we had established relationship, they were obliging and just allowed me to continue to be with them. Also had to do a lot of research. I had to research different topics that came up. It was not a Christian spirituality group. It was a spirituality group. So I had individuals who were Buddhist, atheists, Catholic, Jehovah's Witness. So I had to also understand what framework they were coming from in order to incorporate all these different beliefs in group. Another part of it, I had to also be able to have my framework of what I wanted to cover, but also have room for flexibility. Many people will come back from their place of worship with questions because many of the times some of their religious leaders were talking at them but not talking with them. So they had different questions and different things that they wanted to bring to the group. Plus they were pressing topics and issues that they were struggling with. So we gave space for that as well. The next slide. So I used a dialogical and experiential process. Dialogical meaning that we just had time to talk. We had time to talk, and I gave them opportunities to share their story, to share their struggles, to cry together, to grow together, and to learn from each other, and to form community, to realize that they're not alone and there's others who understand what they're going through. Some of the experiential things in which I did, I had them write laments. That was a wonderful exercise. We did telling our spiritual stories. I did spiritual vision boards of talking about where they've come from, where they are now, where they see themselves going. We did some mindfulness, meditations. There was one activity where I did some clay building so that they could make their own religious symbols and, what that meant for them. We talked about forgiveness, healing, grief and loss, and reconnection to community or redesigning what community would look like for them. So it may not be going back to where they came from. It may be making a whole different type of spiritual community that they feel welcomed and a part of. Next slide. Cultivation of sacred meaning in human experience. What is the length of group? The groups were an hour. So I did 10 weeks. I had different themes each week, and they were an hour each week. So we also talked about meaning making. Where did faith come from? We talked about the things in our religion that was handed down to us and how we process those things that were given to us that may not fit with who we are today. So we talked about that. I used Viktor Frankl, his book, Man's Search for Meaning, to talk about meaning making. Because a lot of these veterans were not only dealing with their identity and their orientation, but they were also dealing with traumas and forms of suffering. So what does that mean, and how do we use our spirituality to be of support for that? So we did some meaning making exercises as well too. Next slide. So restoring our spirituality. And in this process here, we did a lot of emotional awareness. I realized that within this group, as well as other spirituality groups that I have, that many people are not in touch with their emotions. And from my understanding, emotions and spirituality goes hand in hand. So giving them space to talk about what does it mean to be angry, even if they're angry with God and angry with these other individuals, what does it mean to be hurt by the church and feel lonely and rejected? So we gave space for that. And then also what do we do with it? So we don't want to just sit and have a session of just moaning about it, but now what do we do with it? And how do we now reauthor our story to gain some meaning and purpose? And so in order to do this, please understand that you need to establish some trust, some vulnerability, and have lots of empathy. Being able to connect and have some relational connection here is essential. This is a place of great wounding, but it can also be a place of great healing for these individuals. So you got to be able to make space for that, and know that it's going to take a lot of courage on your own part in order to go there and to be a part of this process. And it says, yes, understanding emotions and feelings and how they are a part of the spiritual selves is good stuff. Thank you. Yeah, it's important. It's important. But you have to also be aware of your own emotions. And you need to be very authentic and sincere with who you are. That's why I said the first step is to know who you are, because for many individuals, their faith group or their endorser may have some issue with providing this type of care. So you have to have some honest reflection of whether or not you can really delve into doing this level of work. And our last slide here, the next slide, Tiffany, is establishing or enhancing spiritual connections and resources. This is how I'd like to end the group. The group is not intended to go on indefinitely. Now, I got to be honest, I've had a struggle with that because we've talked about different things and different people have come back. But the goal is to provide care and support and then launch them back into their community so that they can have ongoing care and support through the different resources there. So they have to have a sense of, wanting to get back involved with their own religious worship, their own rituals and practices in their everyday lives, and particularly using them as coping mechanisms to help get through whatever they're dealing with as far as their mental health and physical health issues. So it's a holistic approach